Good morning, everyone. So thanks for those who are joining us right now in our website and participating in these webinars that we are going to start with the Transition to Transplant project that we have developed with the support of Vertex Canada. And this is a joint project between the CF Canada with Joanna Balsamis participating, Kate Gent from St. Michael's Hospital, and myself from the Toronto General Hospital. So these really are a series of different topics that many people are participating, and we are going to really try to get some help to you and your patients that are transitioning to transplant. So we first of all have to thank our patients, their families, our health providers who have helped us to identify the different gaps, and of course all the participants in the talks that will be giving you information about different topics. So the first talk today is going to be an overview about lung transplant, and this is really an overview that is not going to focus on every specific topic, but it's just to give you a great overview of the lung transplant process. So in order to really cover this, I'm going to go through the lung transplantation for cystic fibrosis and the role of the Toronto Lung Transplant Program, the problems that we encounter and many issues related to the CF patients, criteria for referral and listing, and the differences in care for the patients who have been pre- and post-transplant. So we're going to start with the lung transplantation for cystic fibrosis. And for that, I need to give you a little bit of history and tell you that the first transplant patient that was done in the U.S. was done by Dr. James Hardy. And this was a 58-year-old patient with lung cancer in his left main bronchus. And he was in jail, but he was willing to proceed with this operation that unfortunately was not successful. The patient ran into complications with renal dysfunction. He was put on peritoneal dialysis and died, unfortunately, 18 days after that. So that was the first attempt. And after that, at least 44 more were attempted to be done, but no one of them was successful. And Toronto is very important in the history because that is where we started to do the lung transplant. And this is just to show you, probably it's a little bit blurry, but this is just interesting because this was the ethics application to the Toronto Lung Transplant Program in 1982 for allowing in the hospital to start lung transplant. And this is also interesting just for you as a cystic fibrosis patients and in general, because this was the criteria: patients who were 50 years of age or less, primary pulmonary pathology, of course we know that, but as you can see here, patients with cystic fibrosis were not considered for transplant. Now, the other thing was the patients were totally disabled. We don't accept that anymore. Of course, we know that the patients need to be strong in order to be successful for transplant. And they were really not necessarily 6 months to survive. So today we know the patients could survive longer, and hopefully they will have enough time to be waiting for their transplant. So it was then in Toronto in 1983 when the first single lung transplant was done by Dr. Joe Cooper, and in 1986 the first successful bilateral lung transplant also was done. The immunosuppression since then has been cyclosporine, azathioprine, and prednisone. We do have other medications, but this has been the protocol that we use in Toronto. This is Mr. Tom Hall, who was the first successful single lung transplant patient. He survived 7 years and died, unfortunately, with complications of renal dysfunction due to the immunosuppression. And here is Ann Harrison, our first bilateral lung transplant in 1986 for alpha-1 antitrypsin deficiency. She survived more than 15 years and was doing amazingly well. And of course, the question is, what about lung transplant for cystic fibrosis? And this is just an X-ray to show you the advanced lung disease in one of our patients. And this is the, of course, explanted lungs with these big lesions and damage that occurs in the lungs. And of course, we were wondering why these patients were not considered for transplant. So unfortunately, people saw that because of the multi-system disease that our cystic fibrosis patients will have, they have a lung septic disease, they had poor nutrition, and they probably will have recurrence of the disease, which was a question at that time. The patients were not considered for transplant. And this is also part of the history, but this is a British Medical Bulletin in 1992, where you can see clearly how the cystic fibrosis patients were not considered for transplant. So this really, again, due to the nature of the disease, the malnourishment, and the fear of recurrence of the CF defect. But fortunately, and thanks to Dr. Matthew Jacob and Dr. John Waldworth in Padworth and London, we have the first heart and lung transplant done in a woman with cystic fibrosis in 1985. And of course, this was successful. After that, Dr. Paul Corris, who is still there in Newcastle, created the lung transplant for cystic fibrosis. But of course, the question was, do we need to do heart and lung transplant? And this is a quote from the editor in the CHEST journal. And he says, at least for many years to come, there will be no other alternative therapy for patients with end-stage lung disease. And that, I think, is still a true statement today. So in Toronto in 1988, Dr. Patterson, who was working at that time with Dr. Joe Cooper, then performed the first successful bilateral lung transplant only without heart for cystic fibrosis. So again, fortunately, Toronto has been quite important in the history of the lung transplant. And here is our first cystic fibrosis patient that was transplanted in 1988. And of course, there were some complications as expected for cystic fibrosis patients, so he ended up having what was thought was a bowel obstruction, but of course we know it's a distal intestinal obstruction syndrome. But he did extremely well many years post-transplant, as many of our patients could develop kidney dysfunction many years post-transplant. I think that was more than 15 years after his lung transplant that he developed kidney dysfunction, received a kidney transplant also, but he had an amazing quality of life, and he was an amazing ambassador for transplant for cystic fibrosis. Now, we don't know that we have now new medications, we have plenty of new antibiotics, and we can really improve the survival of our cystic fibrosis patients. But despite that, many of them will come to transplant. It's good to know that our survival before transplant has increased, and this is the report from Dr. Stevenson in 1915, that she was able to show that the median age of survival in Canada was 50.9 years. And of course, the death has been later in life with a median of about 35. So this is clear, and of course, we can see also how the number of transplants for cystic fibrosis has improved over time. So this is from the Journal of Heart and Lung Transplant, a report in 2017. But as you can see, we have more than 8,000 patients that have been transplanted around the world, most of them bilateral lung transplant. And these single lung transplant patients were then probably in the early experience of the lung transplant. So it's evident cystic fibrosis patients make a good proportion of the transplants around the world. This is looking at the indications, and this is the purple line where we can see, again, cystic fibrosis patients have increased in number progressively as the years go by. And the survival, of course, is great, and here is, again, why today, despite all the fears, cystic fibrosis patients are considered good candidate for transplant. The survival and the quality of life post-transplant is amazing. Now, what about in Canada? So this is part of the data that we were able to collect, and we can see also how, over the years, the transplant for cystic fibrosis has increased. We have 4 centers in Canada, but many CF clinics where all our patients should be able to be approached about transplant and be able to know that we are there for them when the disease progresses to the point that they need lung transplant. This is just an overview of the indications for transplant in Toronto, and cystic fibrosis really is approximately 20 to 25% in the adult population. When we look at the pediatric population, we can see that it's 50 or slightly more indication for cystic fibrosis. So again, a good amount of patients could be able to benefit from transplant. And when we look at the survival post-transplant, again, Dr. Stevenson in 2015 published how the survival has increased after the initial years of the transplant. And after 2000, you can compare the survival at 1 year, at 5 years, and 10 years post-transplant. So again, we are really able to demonstrate that the patient can do extremely well post-transplant, and we all have a role to play on that. Now, of course, as we said, cystic fibrosis is not been just easy to transplant. There were plenty of problems that have been identified since the beginning, and we can divide them in surgical and medical. So the surgical problems, of course, are related to the pleural adhesions, the higher possibility of bleeding just because of the previous infections. The chest cavity is quite fixed in these patients, and they could have more bleeding. That has not been a major issue. Our teams have been able to really work through that. In terms of the medical complications, of course, probably the infections are the main ones. Despite removing the lungs, the patients will have still the infections in their sinuses due to the same composition of the mucosa. And if they come to transplant later in life, they could have more than 1, 2, 3 different, not only bacteria, but other different organisms that can cause problems. Many of them we know are associated to poor outcome, especially the Burkholderia cepacia complex. We have many more identified over the years that we don't even have enough numbers to be able to say what would be the impact in transplant. We do know, again, the Burkholderia cepacia, especially the Cepacia ET12, has been reported to have increased mortality post-transplant, and that was identified even early post-transplant. And that, despite all the segregation we know could cause high mortality post-transplant, especially during the first 6 months post-transplant, due to the combination of immunosuppression and bacteria, of course, that is quite resistant. We published that in 2001, and we have done plenty of changes that unfortunately have not impacted the outcome. We still transplant them. We still have patients mainly coming from Ontario and the East Coast with cepacia. Despite that, we have had some successes in Toronto, and that is why we continue to offer these. But not every program will be able to do that, and we know that it's considered a contraindication for transplant in many centers. Now, other infections include the fungal infections, and especially Aspergillus. Up to 50% of our patients could come to transplant being with Aspergillus in the lungs. So we just need to define which ones are the ones that we need to treat. Mycobacterium is also part of the infection that these patients could have. And viral infections, in many occasions, the younger that they are transplanted, the higher the risk of infections. And of course, many of our donors are probably older than our patients, so the possibility of infection is almost 100% of them. So of course, because they haven't had this previous exposure, they could develop really worse infections. Those risks will be reviewed later on by our infections specialists. Now, other medical problems that we identified clearly were the development of diabetes post-transplant. So this comes from a paper that was published by Denis Hadjidratis in 2005, where we definitely see how post-transplant the development of cystic fibrosis-related diabetes is there for many, many of our patients. And that is related to the use of steroids and tacrolimus as the main problem. But we do know the older they are, the higher also the risk of developing cystic fibrosis-related diabetes. With renal dysfunction, we also see quite that prevalent in our patients, and we also have noted that our CF patients may end up developing early renal dysfunction requiring dialysis. Most of them, fortunately, are able to get off dialysis early post-transplant. But these have been also seen in our patients, and we do know the calcineurin inhibitors, which is part of the immunosuppressive medications that we use, could cause the kidney dysfunctions. We inform our patients about this. We have the feeling that patients who have been exposed to aminoglycosides could have higher incidence of renal dysfunction post-transplant. And Dr. Kwon has also identified the older age female gender and CF-related diabetes as a risk of developing renal dysfunction. So again, all of these factors will increase the risk of renal dysfunction. What about gastrointestinal complications? So again, knowing that our patients have pancreatic insufficiency and have problems with medication absorption and levels will impact the immunosuppressive medication. So we know, first of all, that if we use antibiotics, which we use very often early post-transplant, we will have to adjust according to the antibiotics. And our immunosuppressive medications will require adjustments very often, and in many occasions, the use of other medications trying to achieve the levels that we want in order to protect the lungs from being rejected. We have also identified that many of our patients will develop other complications, and that was published also by Dr. Marita Gilliand in 2003. And we used a survey to identify what were the major problems. And by far, of course, distal intestinal obstruction syndrome was very common, especially early post-transplant, even in patients who did not have any history prior to that. So we cannot be confident that patients who have never had those problems, they won't have it post-transplant. And early post-transplant, due to the administration of medications for pain, that's where we are going to see this classical presentation of distal intestinal obstruction syndrome, which is presented with accumulation of stool mainly on the right side of the colon. The other risk that our patients face, both pre and post-transplant, but definitely higher post-transplant, is the cancer and gastrointestinal tract, which was clearly also published by Dr. Nelia in 1995, where we know that the risk of cancer in the digestive tract is high in our patients. So we have to be very aware of that, both before and after transplant, especially on patients who are having a previous history in the families of GI cancer. So we need to really work on screening these patients earlier than later. In terms of other complications, osteoporosis, of course, is identified. All of our patients, not necessarily post-transplant, will have a bone mineral density that's under the normal values. But of course, post-transplant with the use of corticosteroids and the previous use of corticosteroids in many of our patients pre-transplant, maybe the immobility, lack of exercise, and of course the malabsorption will increase the risks that are evident post-transplant. So we do treat these patients post-transplant with many medications. Again, our experts will discuss about what kind of treatments we could suggest. The prevalence is very high, and the vertebral fractures and non-vertebral fractures could achieve to 20% post-transplant. So again, that's another of the complications that we need to be very aware of. Now, moving on to criteria for referral and listing and the transition to transplant. So this is the main focus of this. And of course, in order to start thinking when is the time to refer, we continue using what has been used not only here but around the world. And it was the work from Kerem that was published in 1992, where many patients were evaluated. And when look at the FEV1 that was less than 30%, the risk of mortality was 50% in the following 2 years. So that has been the criteria that had been used. So FEV1 less than 30% being the main one to consider referring to transplant. But this is really what we have been working on. We think that patients with cystic fibrosis should probably be referred earlier than that. Probably it doesn't really matter, the percentage could be 40%, could be 50%. It really depends what the needs for every patient is and how much time we feel that they are going to require in order to accept this transplant and how much they will need to be on that transition to transplant. So we do also know that the International Society for Heart and Lung Transplant has assumed that this is the number, but also the presence of hypoxemia, hypercapnia are indications to refer for transplant. A part of that, we have progression of the disease with a need of permanent antibiotics or patients who have required ICU admission. Those patients should be referred for transplant. Patients who have recurrent massive hemoptysis, they need to be referred to transplant, and of course patients who have refractory or recurrent pneumothoraxis, those patients also should be referred to transplant. So this is what the International Society for Heart and Lung Transplant has accepted as the main referral numbers. In terms of candidate selection, this is just for you to know that, again, there are programs that won't accept patients who have bacteria such as the Borrelia specia or Aspergillus. In the past, there was contraindication to proceed with transplant with patients who had previous pleurodesis, patients who were on mechanical ventilation, patients who had liver disease, patients with cirrhosis who used to reject to transplant, or heart diseases. Today, those contraindications are not existing anymore. We have a way to deal with them. We actually not only transplant for mechanical ventilation, but we also, as you know, we use ECMO, we use Novalung as a bridge to transplant. We do combined organ transplantation also for patients who have other organ end-stage diseases. Now, what about the transition to transplant? How the patients see this? So they see, of course, a huge surgical procedure, which is a real idea. But, of course, they see a great possibility of improving survival and improving quality of life. And that's the way that they choose the transplant. We, of course, will be facing unknown risk that we just cannot predict. And, of course, it's a lengthy process since the moment we start thinking about transplant. Now, these patients will be facing challenges that we need to identify clearly. So they are physical challenges because, of course, they have deterioration of their health. They have deterioration and challenges with nutrition. They have need for longer treatments. They have admissions to the hospital that were more often than before. And, of course, many of our patients have grown to the moment that they have their own families. They are completely independent. So the challenges will be also emotional. They have limitation in their physical activities, they have loss of independence, they have limited social life, and they have limited possibility of traveling. They have acquired work responsibilities because they have been very productive. They have work problems with insurances, and they have an important financial impact. These challenges also will impact the families. The families will need more support. Again, they were independent. Now they need to face these new challenges. They have emotional struggles. They have limited family and social life. Again, they have work interruptions because they need to support their loved ones to go through this process, and they have, again, important financial impact. Now, these challenges are not only for the patient and the families. We, the healthcare team, have to be aware of the challenges, and we need to really be able to or have to be able to provide more medical support. We need to have social work, psychiatry, psychology to get them ready to provide support for our patients. Nutrition has to be probably more often on top of our patients. And physiotherapy, we need to really, despite the progression of their diseases, despite the limitations, we really need to continue being aggressive with physiotherapy. So the question is when to start this process, when to start this transition to transplant. Well, I think that we need to start very early. Never is probably too early, and it's better to say it's early than to say it's too late. So we do have to understand, and that's what we have learned through this transition process and the information that we have gotten even through our patients, is that they require longer time to accept these options for the reasons that we have said before. We need to have them being seen by a transplant respirologist so that they can hear all the good and the bad things about transplant. And going through the assessment allows patients really to learn more, to have more education about the transplant process and what they need to work by the time they get to the lung transplant. The message that we need to transfer to our patients needs to be consistent. So we need to work on being realistic. We need to, again, show them the good and the bad things. But more important than that, to be able to say this is a good hope and not present it as another disease. There are things that we will need to really work on, and if there are complications, we'll need to deal with them. But we need to really present this as a real hope for survival and quality of life. Always we'll have people who are willing to talk to our patients, and the main mentors and the best mentors are our own patients who have gone through this process. Now, in preparation, our teams need to be able to provide more chest physiotherapy, more nutrition evaluation, exercise, social and financial support, as I mentioned before. And again, there is never a shortage of looking for ways to improve the way to inform our patients and educate our patients through discussions, to pamphlets, to family meetings, etc., that we should repeat as many times as we need it. Now, when we proceed to the assessment, so we need to support our patients and then teach them and understand where they are now so that we can really work on improving or working on to make them a good candidate. So we need to explain about the future changes. And for example, in cystic fibrosis-related diabetes, we want to teach them about that even before they really become cystic fibrosis-related diabetes patients. They want to really learn about that before. We need to maximize the nutrition. We need to teach them about how to work with the distal intestinal obstruction syndrome and maximize their nutrition for the best outcome post-transplant. And this is very important: exercise, aerobic strength, and the oxygen requirements. Please work with them, making them very strong and very capable. There are topics that we need to really talk about, and again, our experts will discuss about this, but we need to talk about sexual life. We need to prepare them and use vaccines to avoid complications that could be worse post-transplant. We need to discuss with them about family planning and pregnancy, that many of them will still like to think about our future families. Now, when we leave the patient, so in general, it's really quality of life. The patient has to really decide, where is my life? Where is my quality of life that I want to proceed with this procedure that is not perfect, but it's offering me the best quality of life? So, of course, the presence of oxygen-dependent respiratory failure, hypercapnia, pulmonary hypertension are factors that are making us to think this maybe is getting closer, but the main thing is the patient and their quality of life to proceed with transplant. Now, of course, the transplant program will offer many times relocation need. Again, patients will need to have support in different ways to go through this process with relocation, without their families, etc. So we need to really be prepared for that. In the future, we hope this will be not a need, but for now, and in order to offer the best preparation for our patients, still it's unfortunately needed. While they are waiting, we will have a role for the transplant program and a role for the CF program, making them really the best candidates, working again with all these possible complications, infections, use of bypass. I think that is very important is to talk about palliative care. What are the wishes for our patients if things go wrong both before and after transplant? So again, plenty of our experts will be talking about this and how we are dealing with this. Finally, and very in a short way, what are the differences in care of CF patients pre and post-transplant and other challenges? So this is where many of our health providers will have to focus. So these patients are going now through a transition that is going to become the new life. So they are going to be in transition permanently because they now are seeing a new hospital, a new team, and their appointments will be really with different people. Their coordinators will be the main source of contact, and then we need to really try to maintain the best communication with our CF teams. Many times our patients don't know where to go. Do I need to go to transplant with this issue, to the CF, to my family physician, etc.? These are things that really we need to try to keep a unified way to deal with this. In general, we encourage our patients to go to see our CF colleagues every maybe 6 months, a year post-transplant. But in many occasions, if the patients are dealing with the cystic fibrosis-related diabetes, we do have our own clinic with the CF team where they are going to be seen like in a matter of weeks after the transplant. We have to keep in mind that our patients could now develop problems related to microangiopathy that in the past we were not really concerned about. But we have seen patients, again, with progressive renal disease or even MIs that we have seen post-transplant. We have, again, to make them aware, and all of our teams, not only in the transplant, but the CF and the CF clinics, we need to be aware of being prompt to do screening for cancer and GI complications. So this is really what I wanted to show you in really a quick overview about the lung transplant process. And then to summarize, we really have to say that contrary to all expectations, and despite CF being a systemic disease, we have patients who have evolved to the moment that are the best candidates, and actually we know that many programs will prefer now to transplant cystic fibrosis. The CF patients in general are very young, with excellent compliance, and have shown to obtain an excellent quality of life after transplant. We have to understand that CF patients are surviving longer, and more patients probably will be waiting for transplant as the years go by. So transition, again, requires our team to recognize this new status in life. We need to help the patients with care not only provided by the CF team and the transplant. We need to improve the communication with all the clinics around Canada and hopefully around the world, so that we can work on ways to try to create guidelines in order to help our patients. Again, we are going to start here in Canada, but we hope that this will be something that we can work with other centers out of the country. The success of the transplant definitely starts with a good candidate. So we are responsible to create those good candidates so that we can make them successful after the transplant. I think that's it for today. Thank you very much to everyone.
Thank you very much. Oh, sorry.
Yeah, go ahead.
Oh, thank you very much, Cecilia. I just wanted to open the floor now, so if there are any questions, you can either use the chat feature that's at the bottom of the screen, or you can use the raise the hand function, and Cecilia can unmute you so you can ask your question live.
Okay. I think I'm transferring to Joanna so that she can coordinate the questions from her side. Maybe I'm having a little bit of difficulty here to see all the display people. Maybe I see Joanna coming here. All right. Maybe no question?
Yeah. No, it doesn't look like it. I don't see anyone raising their hand, so I think we'll leave it at that. There is another webinar coming up. One thing I'll mention is that if you're interested in seeing the future webinars, you can go on Cystic Fibrosis Canada's website. Under our healthcare tab, you'll see the Transition to Transplant program listed there with all the upcoming webinars, and there will be links there to register to future ones, and we'll also be sending them out by email. So thank you very much.
Thank you.
Gary.